Okay, let's dive in. We're tackling a disease that affects hundreds of thousands of people every single year around the globe. Oral cavity cancer.
That's right.
And right away, here's a fact from the source material we're using today that really, grabs your attention.
Mm.
Despite all the advances in surgery, radiotherapy, our understanding of cancer biology, the overall prognosis for this disease, it hasn't really changed much in decades.
Yeah,
The 5-year survival rate is still hovering stubbornly around 50%.
50%. It's stark, isn't it? That number alone, it just underscores the persistent challenge this cancer presents.
It really does.
I mean, we've made huge strides in understanding the sort of nuts and bolts, but translating that into consistent, widespread improvement in patient outcomes globally.
Well, that's the ongoing puzzle.
It is. And our guide for this deep dive is some truly foundational material, specifically a chapter on oral cavity cancer from the 28th edition of Bailey and Love's Short Practice of Surgery. Ah, Bailey and Love's. Classic. That's the kind of comprehensive, detailed source that clinicians and surgeons really rely on.
Exactly. It gives us that bedrock understanding, doesn't it?
Absolutely. From the cellular level all the way up to how we actually approach treatment. It lays it all out.
So our mission today is to really unpack this critical knowledge. We're going to get precise about what oral cavity actually means according to this source.
Yeah, the definition is key.
Understand the global patterns, where and why this cancer shows up. Pinpoint the key causes and risk factors, and there's some unexpected turns there. We'll walk through how it's diagnosed and staged using the latest systems, explore the intricate world of surgical management and reconstruction.
Which has changed massively.
Hugely. We'll look at the role of other therapies and understand what happens if the disease recurs. Basically, we want to go deep, cover everything this source gives us to really understand this topic, like the professionals who deal with it every single day.
It's about seeing that comprehensive picture, isn't it? The epidemiology, etiology, pathology, staging, management. This text provides a really detailed roadmap for that.
And this isn't just abstract science, is it? This is a disease that profoundly impacts people's lives, their ability to eat, speak, connect with others.
Absolutely. The functional impact is enormous.
And as we'll see, its impact is felt very differently depending on where you are in the world.
Yeah.
It's directly tied to lifestyle and environmental factors.
That geographical variation is one of the most striking things.
Understanding this is vital, not just for those in medicine, but really for anyone who wants an informed perspective on global health challenges. We're going to take you step by step through the essential insights from this text.
Okay, sounds good. Where do we start?
Let's begin with the global landscape, the epidemiology. The source tells us there are approximately 350,000 new cases of oral cavity cancer diagnosed worldwide each year.
350,000, it's a big number.
And when we talk about oral cavity cancer in this context, we're almost always talking about one specific type, squamous cell carcinoma, or SCC.
Right. Over 95% are SCCs. They arise from those lining cells in the mouth, the squamous cells. That histological type is fundamental.
And historically, this has been a disease that affects men far more often than women, hasn't it?
It has. The source cites 2015 data showing age-standardized rates of 5.8 per 100,000 in men versus 2.3 in women.
So roughly a 2-to-1 male dominance, maybe a bit more?
Yeah, around that. But the source does note that this ratio has narrowed somewhat recently.
Interesting. Still likely reflects differences in tobacco and alcohol use, though.
That's the thinking, yes. Those consumption patterns over time. Which brings us to a really critical insight from the source.
Go on.
Incidence varies considerably across the globe. This isn't uniform at all. And this wide variation, it's a direct reflection of differing risk factor exposures around the world.
Okay, this is where the global health implications really hit home. 2/3 of all oral cancers occur in low-income countries.
2/3, that's huge.
And get this, half of those cases are in South Asia.
Half in South Asia alone.
The situation in India is particularly acute. The source states 100,000 new cases every single year, an incidence rate of 20 per 100,000. And oral cancer accounts for over 1/3 of all cancers diagnosed in India.
Wow. Over 1/3 of all cancers. Just think about that scale of impact. It's a massive public health burden driven by specific regional habits.
The source lists other high-incidence areas, too.
It does. Southeast Asia, Papua New Guinea, parts of Western Europe like Portugal and France, certain Eastern European countries, Slovakia, Hungary, are mentioned.
Hungary having very high rates, I recall.
Yes, some of the highest. And parts of Latin America, like Brazil, it's quite widespread in pockets.
And the text points out something fascinating, that the specific site within the oral cavity where the cancer most commonly arises can give you a big clue about the likely cause in that region.
Absolutely. It's detective work based on location. For instance, in India and Southeast Asia, you often see it in the buccajingal area, that's the lining of the cheek and gum near the back teeth, and the retromolar area, just behind the last molar.
And that's linked to?
Directly linked to the widespread use of betel quid and smokeless tobacco in those areas. The carcinogens are held right against that tissue.
Right. Contrast that with, say, Eastern Europe.
Exactly. In Hungary, for example, where habits might differ, the source says the lateral border of the tongue and the floor of the mouth are much more common sites. The local exposure really dictates the local risk pattern.
What about the U.S.?
Looking at the U.S. using SEER data, the age-adjusted rate is around 11.2 per 100,000 per year, with a death rate of about 2.5 per 100,000.
Still significant, obviously, but considerably lower than those high-incidence spots in South Asia or parts of Europe.
Definitely lower, yeah. And the standard cancer patterns hold true in many ways. Incidence increases with age. Most cases are diagnosed after 50, mean age around 62.
And the link to socioeconomic status.
There's a strong correlation with lower socioeconomic class, which is often tied back to higher exposure to those traditional risk factors like smoking and alcohol.
The source highlights a trend that is, well, particularly worrying and maybe a bit of a puzzle.
Yes, the increasing incidence in younger patients, specifically those aged 45 or younger.
And what's really notable here, the source says, is that many of these younger patients don't have that history of heavy smoking or drinking or betel quid use that we typically see in older patients.
Exactly, and that's a critical question for researchers and clinicians right now. If the traditional culprits aren't the primary drivers in these younger cases, what else could be at play?
Right. Are there other environmental factors, maybe genetic predispositions or infections we don't fully understand yet?
Precisely. It's a significant area of focus. This trend is really pushing the field to look beyond the usual suspects for this group.
Okay, let's talk prognosis and survival. For early-stage oral cancers, the source says the 5-year survival is actually quite good, around 80%.
80%. That shows that if you catch it early and treat it effectively, the outcomes can be very positive. It's a testament to our current treatments when applied early.
But, and this is the kicker we started with.
Yes, the key challenge. The source points out that the overall 5-year survival rate, looking at all stages combined, has not markedly improved despite all the advances in surgery and adjuvant therapy over the years.
Still stuck at 50%.
Stubbornly at 50%. It's a tough number to hear, especially when you consider the scale of the problem globally.
And even worse in some places.
Yeah, in South Asia, where incidence is highest, the survival rates are often even lower. The text mentions reported rates as low as 35% in India.
Wow. That really highlights the disparity, doesn't it? The urgent need for better prevention, earlier detection, improves access to care globally.
Absolutely. So that's the landscape. A widespread disease, dramatic geographical variation tied to risk factors, this concerning trend in younger patients, and an overall outcome that hasn't shifted significantly despite our tools.
Which brings us right to the next question. What specifically causes this?
Exactly. Let's unpack the etiology and risk factors.
The source is very clear on the long-established, the heavy hitters for OCSCC.
Yeah, the big three. Tobacco, alcohol, and betel quid.
And they emphasize a strong dose-response relationship, right? The more you're exposed.
The higher your risk, absolutely. And they give a precise definition of betel quid, too.
What is it exactly?
It's a mix. Areca nut, catechu, and slake lime, usually wrapped in a piper betel leaf, and it's often used with smokeless tobacco. That combination is a potent carcinogen.
Directly linked back to those incredibly high rates we talked about in South Asia.
Directly. Now, there's a really important nuance the source makes regarding HPV, human papillomavirus.
Right, because HPV is a major driver of cancers in the oropharynx, isn't it?
Yeah.
The back of the throat, tonsils, base of tongue.
Exactly. In the oropharynx, HPV causes 50–70% of SCCs. But the source states that for cancers specifically in the oral cavity, the front of the mouth transcriptionally active HTV accounts for only a small percentage, around 5%.
Okay, that is a crucial distinction. Because we hear so much about HPV and head and neck cancer.
We do. And interestingly, in the oropharynx, those HPV-positive cancers often have a better prognosis than the HPV-negative ones.
But not in the oral cavity.
That's what the source says, that potential for a more favorable outcome does not appear to be conferred for HPV-positive cancers located in the oral cavity itself.
That's a really vital point for listeners. You can't just lump all head and neck cancers together regarding HPV.
Absolutely not. What about other risk factors? Does the source mention others?
It does. Previous exposure to radiation, chronic infection, immunosuppression, and certain hereditary conditions.
Okay.
Under hereditary conditions, the source adds a little historical context, mentioning key figures. Guido Fanconi, for instance.
Ah, Fanconi anemia.
Right, that rare genetic disorder affecting DNA repair, leading to bone marrow failure and early cancers.
And Life-Romany syndrome, too.
Yes, Frederick Paley and Joseph F. Romany Jr., who identified that familial cancer syndrome linked to various cancers like sarcomas and breast cancer.
So while these hereditary links are rare compared to tobacco and alcohol, they represent specific genetic pathways that can lead to oral cancer.
Okay, let's move to another significant area. Pre-malignant or potentially malignant lesions.
Ah, yes, the visible warnings.
The source clarifies that while most oral cancers seem to arise from normal-looking tissue, there is this distinct group of abnormal mucosal changes from which cancer can develop. The source prefers the term potentially malignant lesions.
And they list several types. Leukoplakia,
The white patch.
erythroplakia,
The red patch.
erythroleukoplakia, the mixed one, proliferative verrucous leukoplakia, or PVL, oral submucous fibrosis, often linked to betel quid, oral lichen planus and lupus erythematosus, and some inherited conditions too.
They give clear descriptions for the main visual ones. Leukoplakia, that white patch or plaque you can't rub off, can't classify as anything else. Erythroplakia, a bright red velvety patch, also unclassifiable.
And critically, they point out that erythroleukoplakia, the mixed red and white one, sometimes called speckled leukoplakia, that carries the greatest risk for malignant change among these lesions.
But managing these is tricky, right?
It is. The source acknowledges the challenge, partly due to inconsistent naming conventions internationally, and because their exact natural history, which ones will progress, which won't, isn't always clear.
There was a review cited showing huge variability in transformation rates for leukoplakia.
Yes, a 2016 systematic review reported malignant transformation rates ranged wildly from just 0.13% right up to 34.0%.
Wow, that's a massive range. Makes predicting the future for any single lesion really hard.
Extremely difficult. So risk assessment becomes absolutely key. The source emphasizes that erythroleukoplakia, PVL, and dyskeratosis congenita are considered highest risk.
And you also have to weigh clinical factors,
Yeah.
size, location, ongoing carcinogen exposure.
Exactly. And biopsy is essential. You need that tissue diagnosis to confirm what it is and, crucially, to check for dysplasia, those abnormal cell changes.
Which could be graded mild, moderate, severe, or it might already be malignant.
Right. The source includes a summary box listing factors linked to increased risk of malignant change in these lesions if they show dysplasia. Some are intuitive.
Like larger size over 200 millimeters or having multiple lesions.
Yeah, or a non-homogeneous speckled appearance. But some are less intuitive.
Like female sex,
Oh,
given overall lower incidence in women.
right. And non-smokers,
Okay.
which is interesting. It suggests that perhaps for non-smokers who develop these dysplastic lesions, maybe the underlying cause or the biology of the lesion itself is different, possibly more aggressive.
That is interesting. What else increases risk?
Certain locations are higher risk, like the lateral border of the tongue or the floor of the mouth.
And critically, the source notes that even if you surgically remove one of these potentially malignant lesions,
It doesn't eliminate the risk entirely. A new lesion can form, changes can recur elsewhere, so ongoing surveillance is absolutely necessary for these patients.
Okay. Finally, on causes, the source touches on molecular biology. Insights from the Cancer Genome Atlas, TCGA, specifically for HPV-negative head and neck cancers, which applies to most oral cavity cancers,
Yeah, what does it say about gene mutations?
identifies the two most frequent, P53 mutations in a striking 83% of cases,
83%, that's huge.
and CDKN2A mutations in 57%. This genetic landscape is quite different from what you see in HPV-positive oropharyngeal tumors.
Right, those tend to have fewer mutations overall and often keep their normal wild-type P53 gene.
This molecular data gives us a deeper understanding, but the source adds a really critical point about current clinical practice.
Let me guess it doesn't directly guide treatment yet.
Exactly. They explicitly state that as of now, the standard of care for managing head and neck SCC, including oral cavity cancers, is not based on or influenced by this kind of genetic profiling or molecular biology results.
Right, so it manages expectations. The research is vital, points to the future, but it hasn't translated into routine clinical decision-making for standard treatment based on a tumor's genetic profile. Not yet, anyway.
Okay, so we've covered the scale, who gets it, what causes it, what it looks like microscopically, visually. The next essential step, staging, determining exactly how far the disease has spread.
Staging, absolutely fundamental. It's how clinicians document the precise size, location, extent of the tumor.
It's the basis for the treatment plan, right?
Absolutely. And for discussing prognosis clearly, realistically with the patient. Plus, it allows for comparing outcomes across different treatments and centers globally. You need that common language.
And the standard system used worldwide, detailed in the source, is the UICC AJC TNM's staging manual, currently the 8th edition.
That's the one. And the 8th edition brought some really significant changes, specifically for oral cavity cancer staging.
What were the biggest updates?
Two stand out. The formal inclusion of depth of invasion, DOI, for the primary tumor, the T stage, and the recognition of extranodal extension, ENE, as a factor that upstages nodal disease, the N stage.
And these weren't just arbitrary changes.
Not at all. The source emphasizes they were made because DOI and ENE were reliably shown to be significant negative prognostic factors. Including them gives a more accurate way to stratify patients and predict their likely outcome.
Okay, let's break down the T stage describing the primary tumor. How's it determined?
Clinical exam, maybe an examination under anesthesia, EUA if needed, and mandatory radiographic assessment, CT or MRI scans.
And that crucial point about DOI again.
Yes. While imaging can estimate it, depth of invasion is definitively determined pathologically by the pathologist looking at the surgical specimen after removal.
And the definition.
It's precise. The measurement from the basement membrane of the closest normal mucosal surface down to the very deepest point the tumor cells have invaded. A microscopic measurement.
And this microscopic depth is now embedded right into the T staging. Looking at table 53.1 in the source, you see how surface size and DOI combine. A T1 tumor is small, right? 2 centimeters or less.
And shallow, a DOI of 5 millimeters or less. Both conditions must be met for T1.
But if that same small tumor, 2 centimeters or less, invades just a bit deeper, say more than 5 millimeters, but still 10 millimeters or less.
It's immediately upstaged to T2, or alternatively, a larger tumor between 2 and 4 centimeters, but still with a shallow DOI, 10 millimeters or less, is also a T2.
So T2 covers 2 scenarios based on size and depth. What about T3?
T3 is either a tumor larger than 4 centimeters on the surface or any tumor, regardless of surface size, that has a DOI greater than 10 millimeters.
Okay, so deep invasion, even if the surface lesion isn't huge, automatically bumps it to T3. That really highlights the importance of depth.
It does. It indicates more aggressive biology than T4 represents advanced local disease.
T4A is moderately advanced.
Yeah. Right. Meaning it's invaded adjacent structures. For lip tumors, maybe cortical bone, the inferior alveolar nerve, floor of mouth, facial skin. For oral cavity tumors, invasion into structures like the cortical bone of the mandible or maxilla, the maxillary sinus, sin of the face.
But there's a caveat about bone involvement.
Yes. The source adds that superficial bone erosion or just involvement of a tooth socket from a gum tumor isn't enough for T4A. It implies more substantial bony invasion.
And T4B?
That's the very advanced stage. Invasion into structures like the masticator space, pterygoid plates, the skull base, or if the tumor is encasing the internal carotid artery. These are often considered potentially unresectable.
The source includes a figure, 53.2, showing survival curves.
Yeah, that figure powerfully illustrates the impact of T-stage and DOI. You can literally see the survival curves dropping off more steeply for higher T stages. Visually reinforces that deeper invasion leads to worse outcomes.
Makes sense. Now, the end-stage regional lymph nodes. The source mentions a standard anatomical system for the neck nodes.
Yes, dividing the lateral neck nodes into 5 levels based on anatomical landmarks. Figure 53.3 shows this.
And the typical spread pattern for oral cavity SCC.
Usually 2 levels 1, 2, and 3 of the neck. However, the source mentions that tumors on the oral tongue carry a risk of skip metastasis.
Meaning?
The cancer cells might jump directly to nodes in levels 3 or 4, bypassing the expected levels I and 2, different from oropharyngeal cancer patterns.
And here's where extranodal extension, ENE, comes into the end stage in the 8th edition. Table 53.2 details the end categories.
Right, and they're based on the number of involved nodes, their size, their location, ipsilateral, contralateral, bilateral, and critically, the presence or absence of ENE.
And ENE means the cancer has broken through the node capsule.
Exactly. The source reiterates that ENE is a reliably shown adverse prognosticator in all oral cavity tumors. Its presence immediately signals more aggressive disease and results in upstaging the N classification, sometimes regardless of the node size or number.
Okay, finally M stage. Distant metastases.
Right. Cancer spread far away. Standard workup includes imaging the chest, checking for spread there, or maybe even a second primary tumor in the lung.
M0 means no distant mets. M1 means they're present.
And if any distant metastasis is found, M1, the patient's overall stage automatically becomes stage 4C. And currently the source says this stage is considered without curative options.
Table 53.3 shows how T, N, and M combine into the overall prognostic stage groups 0, IT, E3, IVA, IVB, IVC.
Yep, that's the final summary stage that guides treatment and prognosis discussions.
So staging gives us the big picture, the macro view. But to really understand the cancer, we need the micro level, the pathology, examining the tumor cells themselves.
Absolutely. And as we said, over 95% are squamous cell carcinomas, reflecting their origin from those lining cells. The source lists less common variants too: papillary adenosquamous, verrucous carcinoma, etc.
When a pathologist looks at the tumor tissue, the source lists specific things they routinely assess, like a checklist for the tumor's microscopic personality.
Exactly. Histological type, tumor grade or differentiation, pattern of invasion, tumor thickness and depth of invasion, DOI, perineural invasion, PNI, lymphovascular invasion, LVI, bone involvement, and presence of cancer in the removed lymph nodes.
Let's look at some key ones. Tumor grade or differentiation based on how much the tumor looks like normal tissue.
Right. The source uses the WHO grading system derived from Broder's classification. Grade 1, well differentiated. Grade 2, moderate. Grade 3, poorly differentiated.
And the prognostic value.
Clear link. Well differentiated G1 tend to be less aggressive. Poorly differentiated G3 are more likely to infiltrate, metastasize, and have a worse prognosis. The source even gives a nod to Albert Compton Broders, the pathologist behind the system.
Pattern of invasion is also noted as important.
Yes, like grade. It describes the shape of the tumor's leading edge as it invades. The UK Royal College of Pathologists classifies this as cohesive versus non-cohesive.
The source again stresses the difference between tumor thickness and DOI.
Yes. Thickness is max vertical dimension from surface to deep point. DOI is from the normal basement membrane to the deepest point. And again, DOI is prognostically more important than thickness, carries greater weight for predicting metastasis, underscores its inclusion in T staging.
Perineural invasion, PNI. That sounds bad.
It is. Presence of tumor cells tracking along or around a nerve. The source gives criteria like tumor surrounding at least a third of the nerve.
And its significance.
It's a major red flag, strong indicator of biological aggressiveness, independent risk factor for neck node spread, local recurrence, and poorer survival overall. Suggests the cancer is using nerves as highways.
Similarly, lymphovascular invasion, LVI. Tumor cells in blood vessels or lymph channels.
Yes. Another marker of aggressive behavior associated with adverse prognosis, often considered alongside PNI and ENE as high-risk features.
Bone invasion. Different patterns mentioned.
Infiltrative, erosive, mixed. And the source notes strong evidence that tumors mainly invade bone by direct erosion at contact, not via existing channels like nerve foramina.
And that T4 distinction again. Superficial erosion isn't enough for T4.
Correct. T4A requires deeper invasion into the bone, not just scraping the surface.
Finally, metastases from a pathology view. HPV-negative neck node mets mean worse survival.
Consistently associated with decreased survival, yes. Most involved nodes are in levels I and II. Skip mets are possible, but less common than in some other head and neck sites.
And ENE cancer breaking the node capsule, confirmed adverse feature, now in staging. Distant mets are rare.
Relatively rare, 2–9% reported, most often seen in patients who already have ENE and extensive neck disease.
Okay, so we have the scale, causes, microscopic behavior. Now the diagnostic journey. How do clinicians actually find these cancers and figure things out? The source outlines the steps.
It starts with a thorough history and physical exam, then biopsy to confirm, then staging investigations, clinical and radiographic, assessing the patient's overall health, comorbidities, discussion at the MDT meeting.
Multidisciplinary team, vital.
Absolutely. Then pathological staging from the removed tissue, and finally, deciding on any needed adjuvant treatments like radiotherapy or chemo.
And the essential first step, the source says.
Unequivocally, Histopathological diagnosis via formal biopsy. That's the gold standard for any suspicious lesion before extensive further investigations. Requires that careful history and systematic exam of the whole oral cavity, oropharynx, and neck palpation.
And radiographic assessment is mandatory once cancer is suspected.
Mandatory. CT and/or MRI are essential for staging the primary tumor and the neck.
The source also introduces sentinel lymph node biopsy, SLNB, for early cancers with no obvious neck spread.
Yes, an established technique in some centers for staging those early CN0 cancers.
Explain the concept again.
It identifies the first lymph node, most likely to receive draining cancer cells. If that sentinel node is positive, it means spread has begun, and further neck treatment, usually a formal neck dissection, is needed.
They also mention examination under anesthesia, EUA. When is that used?
When outpatient biopsy or assessment is difficult, maybe the lesion is hard to reach or the full extent can't be seen properly while awake due to pain or trismus, that difficulty opening the mouth.
And it helps planning.
Big time. Help surgeons plan the treatment accurately, access needed, tumor boundaries, potential reconstruction needs.
When examining the oral cavity, direct visualization is key. Table 53.4 lists cardinal signs and symptoms.
Really useful table. Key signs a doctor looks for: non-healing ulcer present 2 weeks, persistent neck lump, a lesion getting bigger, feeling firm or indurated.
Persistent red or white patches, back to those potentially malignant lesions.
Exactly. A non-resolving inflammatory sore, a soft tissue lesion with X-ray changes nearby, unexplained loose teeth.
And symptoms the patient experiences, often later stage.
Often, yes. Loss of sensation, nerve deficit, chronic earache, otalgia with no ear cause, trismus without clear reason, difficulty swallowing, dysphagia.
Figure 53.4 shows the variety of appearances.
Yeah, from small red-white patches to big erosive lesions. The photos highlight those malignancy features: speckled look, raised rolled edges, contact bleeding, ulceration, and again, limited tongue movement, sensory deficits, trismus, otalgia, dysphagia, usually late-stage indicators.
They also mention synchronous primary tumors, second cancers elsewhere.
Yes, happens in 2.4% to 4.5% of patients, often in the upper digestive tract. Reinforces the need for a thorough workup of the whole region.
Examining the neck palpation is crucial, but not enough on its own.
Not nearly enough. Thorough palpation of all levels is vital, but the source stresses clinical exam alone only has about 74% sensitivity for finding involved nodes. Cross-sectional imaging, CT or MRI, is required for accurate neck staging.
And it bears repeating. A neck metastasis cuts prognosis roughly in half.
Roughly 50% reduction in 5-year survival makes accurate neck assessment absolutely vital.
Biopsy techniques for the primary tumor.
Incisional biopsy is preferred, the gold standard. Practical tip from the source: avoid necrotic dead areas, take a narrow but deep biopsy, not wide and shallow, to get representative tissue. Brush biocytology. Not reliable enough.
For a neck lump.
FNAC, fine needle aspiration cytology, is first line. Highly sensitive, 89 to 98%. Draws cells out for examination, helps differentiate metastasis from oropharyngeal cancer, can test for HPV2, thyroid cancer, lymphoma.
Okay, imaging. Critical role throughout. CT and/or MRI are the gold standard for staging.
Yes, for primary tumor and neck, the aims are clear. Outline anatomical extent and resectability, detect local and distant mets, detect synchronous primaries, monitor response, detect recurrence.
CT scans.
Contrast-enhanced CT, usually MDCT. Rapid, spatially accurate, big advantage. Hard tissue detail, crucial for bone involvement in mandible maxilla, also usual for chest staging.
In MRI.
Advantage. Superior soft tissue contrast. Often preferred for defining the primary extent, especially in tongue or floor of mouth. Gives more info on perineural spread, bone marrow invasion. Sensitivity specificity for mandible invasion around 82%, 67%. Comparable to CT for neck mets detection. T1 for anatomy, T2 highlights pathology.
PTCT. Not first line.
Not for initial staging usually, reserved for specific situations. Suspected distant mets or synchronous tumors, investigating unknown primary site, sometimes post-treatment surveillance.
Plain x-rays or panoramic views.
Limited for detailed bone staging, but main utility is dental evaluation. Essential for planning pre-radiotherapy dental work, finding existing infection inflammation.
Ultrasound.
Non-invasive, chairside, most common use, guiding FNAC of neck nodes. Operator dependent, but useful for detecting nodes. Sensitivity 85%, specificity 79%. Limited value for the oral cavity tumor itself.
Let's revisit sentinel lymph node biopsy, SLNB, for those CN0 patients. No obvious neck spread.
Right. The concept is identifying that first gatekeeper node. The source cites robust evidence from key trials.
DeCruz et al., Hutchison et al.
Yes, showing that for early oral cancer with a clinically negative neck, CN0, doing an elective neck dissection, END, up front leads to better overall and disease-free survival compared to watch and wait and only operating if mets appear later.
That was a huge finding. But END is overtreatment for many.
Exactly. Not all CNABA patients have hidden mets. So doing A&D on everyone means unnecessary surgery for a good number. This is where SLNB helps. Identifies those with occult mets who then need the formal neck dissection. Can also show unexpected drainage patterns.
But there's a limitation, false negatives.
Yes, the sentinel node is clear, but cancer is elsewhere. One study cited reported a 14% false negative rate. And the source notes we still lack direct randomized trials comparing A&D head-to-head against SLNB with survival as the primary outcome.
The source mentions foundational work by Lindbergh and Shaw on neck levels too.
Yes, their anatomical classifications paved the way for selective neck dissection, moving away from radical procedures. And the trials established the role of elective neck management.
Okay, diagnosis and staging done. Let's move to the core treatment, surgery. The source says it's the mainstay, often with adjuvant therapy.
That's right. Surgery, plus or minus adjuvant therapy, is the standard for most resectable oral cavity cancers.
And surgical approaches have evolved massively.
Hugely. A major shift towards more refined, function-sparing techniques, away from the extensive, disfiguring operations of the past, driven by better understanding of tumor biology, more accurate staging, and the revolution of microvascular free tissue transfer for reconstruction.
But survival is still largely driven by tumor biology, especially nodes with ENE.
Primarily, yes. Surgery's role is to optimize outcomes by applying key principles for curative treatment,
Such as?
careful patient selection, considering comorbidities, function, social support, making crucial surgical decisions, focusing on comprehensive reconstruction, and ensuring multidisciplinary team care.
MDT involvement early is key.
Essential. Physicians, anesthetists, physios, dietitians, speech pathologists, everyone involved from the start, especially for high-risk patients, to optimize them before surgery.
And operability, can the tumor be removed? Determined by size and relation to vital structures. T4B might be unresectable.
Exactly. Involvement of skull base, masseter space, pterygoids, internal carotid artery, those make resection very difficult or impossible.
Once surgery is planned, the sequence is airway, access, resection, neck management, reconstruction.
That's the logical flow. Airway management around surgery is critical for safety.
Options range from immediate extubation to tracheostomy.
Yes. Immediate extubation for smaller, simple cases, maybe overnight intubation if unsure, submental intubation, or tracheostomy. It's a joint anesthetist surgeon decision based on risk and ability to reestablish the airway quickly.
And a low threshold for tracheostomy in certain situations.
Yes, the source lists them. Bilateral neck dissection, previous neck surgery RT, large resection with complex reconstruction, difficult airway pre-op, segmental mandible resection, floor of mouth resection with reconstruction. Situations where post-op swelling is a major concern.
Missed. Access surgery. Needed if you can't reach the tumor easily through the mouth.
Right. For safe removal with adequate margins, especially for large maxillary, posterior oral cavity, tongue-based tumors, or after previous treatment limiting access.
Common procedures. Lip split mandibulotomy.
Most common, figure 53.5. Planned cut in the lower jaw allows it to swing open. Great access to posterior areas. Need to be careful not to tear the lining inside.
Weber-Ferguson approach for the maxilla.
Yes, figure 53.6. Excellent maxillary and midface access. Source mentions Sir William Ferguson's historical role.
Tumor resection goal. 1 centimeter clear margin circumferentially.
That's the gold standard, vital structures permitting.
Mandibular resection decisions, if tumor is close to or invading bone.
Critical decisions. Clear infiltrative invasion needs bone removal. Either segmental resection full height, losing continuity.
Or rim resection, marginal mandibulectomy.
Right. Partial thickness, preserving lower border continuity. Used when tumor is very close but not definitively invading to get a good soft tissue margin.
A maxillary resection, different considerations. Thinner bone, sinuses, orbit nearby.
Exactly. Small gum tumors might need transoral partial maxillectomy. Extensive ones involving sinus floor need wider access, like Weber-Ferguson.
Extension into pterygoid space or infratemporal fossa is bad news.
Very poor prognosis. Difficult or impossible to get clear margins. Extension into the orbit usually needs orbital exenteration, eye removal, or combined neurosurgical approach for skull base. Maxillary reconstruction aims for oral seal, facial contour, facilitating dental rehab.
Management of the neck elective or therapeutic dissection.
Therapeutic if nodes are clearly involved clinically or radiographically. Primary RT alone, less common for bulky nodes.
For early stage, C and 0 necks. Strong evidence for elective neck dissection, END.
Strong evidence reinforced by the source, Ref 5, Hutchison et al. Upfront NDs improves overall and disease-free survival versus watch and wait. A key finding.
We discussed the evolution of neck dissection, less radical now.
Yes, towards selective procedures targeting the most likely involved levels. Thanks to work by Lindbergh, Shaw, Refs 6 and 7. For elective dissection in OCSCC, selective dissection of levels I layer 3 is indicated. Ref 7, Shaw.
Purpose of neck dissection. Staging, prognosis, therapeutic, informing adjuvant therapy, and providing vessel access
For free tissue reconstruction, absolutely essential to have those recipient vessels ready in the neck.
Reconstruction, vital part. Decision shouldn't compromise the cancer removal.
Absolutely not. Ablation dictates reconstruction, not the other way around. Primary goals: preserve, restore function speech, chewing, swallowing, oral continence. Aesthetics important too, but function first.
Oral cavity is complex to reconstruct.
First.
Hard, soft tissues, teeth, saliva, nerves.
Highly complex. Guiding principle: replace resected tissue with tissue that's as similar as possible. The reconstruction ladder, figure 53.7, is a useful concept.
Secondary intention, primary closure, grafts, local regional flaps, up to free flaps.
Exactly. Moving up complexity. General principles. Simplest method for the goals: replace like with like. Use vascularized tissue in irradiated field. Always have a backup plan.
Microvascular free tissue transfer, free flaps, revolutionize things.
Absolutely revolutionize head and neck reconstruction. Incredible technique.
Explain how it works again briefly.
Harvest tissue, skin, fat, muscle, bone combo from a distant site. Detach its blood supply, transfer it, then meticulously reconnect its tiny artery and vein to vessels in the neck using a microscope. Restores independent blood flow. Allows moving large amounts of healthy, vascularized tissue to complex defects. Far better function and aesthetics. Replace soft tissue with soft tissue, bone with bone.
For soft tissue reconstruction, common flaps.
Radial forearm free flap, RFFF, anterolateral thigh, ALT flap, are workhorses.
Yeah.
Table 53.5 details their pros and cons, donor site issues, pedicle length, vessel quality, tissue bulk, etc.
RFF, figure 53.8. Thin, pliable, long pedicle. Good for lining modest defects.
Exactly. Where thin, flexible tissue is needed, not much bulk, like cheek lining, partial floor of mouth.
ALT flap, figure 53.9, more bulk. Better for bigger defects or tongue reconstruction.
Much better suited where volume is needed for function, like rebuilding a large part of the tongue for speech swallowing. Can include multiple skin paddles or muscle. Source mentions others too: rectus abdominis, latissimus dorsi, MSAP, lateral arm.
For composite reconstruction, bone and soft tissue. Free flaps are gold standard for mandible defects.
Yes, especially segmental defects. Figures 52.11. Fibula free flap, lower leg, is most common globally. Others: iliac crest, DCIA, hip, scapula, shoulder blade.
Table 53.6 compares these. Factors like bone length quality, implant suitability, soft tissue potential.
Yes, fibula. Good length, reliable bone, good for implants, but artery might have issues. DCIA. Large bone volume, good for implants, but shorter pedicle, smaller vessels. Scapula vessels, often spared atherosclerosis, versatile soft tissue options.
Chimeric flaps mentioned. Bone and soft tissue move independently.
Yes, supplied by branches off same main vessel, good for complex 3D reconstructions.
Principles for mandible reconstruction planning. Interior defects harder. Average defect 6-10 centimeter. Match donor bone curve.
All key points. Slight span reduction in edentulous cases helps avoid underbite look. Free bone can get infected, especially post-RT. Figures 53.1011 show fibula with VSP and DCIA reconstructions.
Maxillary reconstruction aims. Contour, separating mouth sinonasal cavities, soft palate function, platform for teeth.
Correct. The Brown and Shaw classification, figure 53.1, is widely used vertical and horizontal extent, helps guide reconstruction.
Class I defects simpler, local flaps or RFFF often okay.
Often, yes. Just need to separate oral nasal. Classes 3 and IV are much tougher: loss of orbital support, anterior cheek alveolus. Prosthesis alone often suboptimal.
Need to support orbit, restore bone continuity, ideally for implants,
Yeah.
seal cavities, composite free flaps suitable.
Yes, like scapula or fibula, including bone and soft tissue. Though prosthetic obturators are still an option, studies generally show better functional aesthetic outcomes with free flaps for larger defects.
Recent advances. Zygomatic implants, figure 53.13. ZIP flaps.
Yes, zygomatic implants in cheekbone help support prosthetics with massive bone loss. ZIP flap zygomatic implants, perforating a soft tissue free flap, is a newer technique. Allows immediate closure with soft tissue flap, implants go through it, might allow quicker rehab, sometimes avoid bone flap for certain defects.
Finally, virtual surgical planning, VSP, figures 53.14, 53.15, increasing use.
Definitely. Uses patients' CT data, specialized software, to plan the surgery virtually beforehand.
Creates patient-specific cutting guide stints used during the operation.
Exactly. Figure 53.14 shows guides. Surgeon uses them for precise cuts removing tumor and harvesting donor bone. Figure 53.15 shows guides on fibula scapula. Can lead to shorter operating time, greater accuracy, potentially better outcomes. Prefabricated reconstruction plates possible too.
Okay, beyond primary surgery, adjuvant therapy, given after surgery based on pathology.
Typically, yes. Radiotherapy or chemoradiotherapy. Primary CRT is an option if surgery isn't feasible or refused, but surgery plus adjuvant is standard when possible.
Adjuvant RT, usually external beam. Chemoradiotherapy CRT adds chemo, usually cisplatin, as a radiosensitizer for high-risk cases.
Right, for fit patients with high-risk features found by the pathologist, makes radiation more effective.
Indications based on those adverse pathological features. ENE involve close margins, LVI, PNI.
Yes, features linked to higher recurrence risk and lower survival. Source cites consensus criteria. Ref 8, expert panel.
No absolute global agreement, but general consensus. Need adjuvant RT for one major criterion, ENE, or involve margin 1 millimeter, or two minor criteria.
Correct. Minor criteria include close margin, 1 to 4.9 millimeter, multiple involved nodes, largest node 3 centimeter, LVI, PNI, or T3, T4 primary tumor.
Evidence for adding chemo CRT comes from landmark trials. RTOG 9501, EORTC 22931.
Those are the key ones. Looked at adding high-dose cisplatin to post-op RT.
Defined high risk mainly by positive margins and ENE, or ECD as it was called then.
Largely yes, though other criteria varied slightly. The conclusion from analyzing those trials was strong evidence supporting concurrent cisplatin-based CRT in those specific high-risk patients.
The source also introduces immunotherapy as a changing paradigm, targeting how tumors evade the immune system.
Yes, specifically immune checkpoints, key target, PD-1 receptor and its ligand PD-L1 pathway. Blocking this helps the immune system fight the cancer.
And trials showed checkpoint inhibitors prolong survival in recurrent or metastatic HNSCC.
Yes, multiple phase 3 trials showed that benefit in advanced disease.
And the source suggests potential for future research using these inhibitors more broadly.
Exactly. Positive results in advanced disease highlight the potential for research assessing checkpoint inhibition in the wider management of HNSCC, possibly earlier stages or adjuvant settings, though that's still research territory.
Finally, briefly, managing recurrent or metastatic disease. Options if it comes back or spreads.
For limited recurrence spread, oligometastases, in fit patients, curative intent might still be possible with salvage surgery or reirradiation.
But if it's not amenable to that?
Systemic treatment is the main option. Depends on prior platinum chemo exposure. Includes immunotherapy, PD-1 inhibitors, or palliative chemotherapy regimens. Aim is disease control, symptom management.
But prognosis is still poor for these patients.
Unfortunately, yes. Despite options, prognosis for recurrent metastatic disease remains poor.
Which brings us right back to where we started, doesn't it? That statistic, the challenge.
It really does. Full circle.
We've taken a really deep dive into oral cavity cancer, guided by the surgical text. We've navigated the surprising global epidemiology, its links to lifestyle.
The causes, risk factors, including that HPV distinction.
Right. How the latest staging uses DOI and ENE to predict outcome. Those crucial microscopic features like PNI, LVI,
The whole diagnostic journey exam, biopsy, imaging.
and that complex, evolving world of surgery, neck dissection, and the incredible impact of free flap reconstruction.
Plus the role of adjuvant therapy based on risk and the potential of immunotherapy.
We've really seen how everything connects global habits, cell behavior, genes, shaping how this disease is understood and managed.
That level of detail, it's exactly what's needed to grasp the challenges and approaches used by experts in this field.
And this deep dive was aimed at giving you, the listener, that comprehensive understanding, cutting through the complexity to really master the crucial information, just like the professionals navigating this difficult area.
But as we reflect on that plateauing overall survival rate, despite all these sophisticated techniques, and that puzzling trend of more young patients without the usual risk factors, it leaves us with a key question, doesn't it?
What's the next major breakthrough needed?
Exactly. Is it fundamentally different prevention strategies globally? Is it much earlier detection, catching more people at that 80% survival stage? Is it finally harnessing those molecular insights into targeted therapies that actually change the standard of care?
Or is there some factor driving those young patient cases that we haven't even identified yet?
What frontier must we conquer next to truly move the needle and improve outcomes for oral cavity cancer patients worldwide?
Something to keep considering after today's deep dive.